Welcome back to the deep dive. Our mission, as always, is to take these dense stacks of research, the complex textbooks, and really distill them into the core knowledge you need. Today, we are strapping in for a pretty sophisticated journey into the operating theater. We're focusing specifically on the left nephrectomy.
And this is definitely a surgical deep dive, but I want to be clear, we're not just looking at clamps and sutures here.
Right.
We're examining the complete intellectual journey a surgeon takes. It starts with the surprising history hidden in the patient's anatomy, and it goes right through to the radical shifts in oncological decision-making we've seen over the last decade.
So the real goal is to understand how top surgical teams anticipate and navigate that extreme complexity. We're talking about the silent threats, right? The pedicle encasement, the adjacent organ involvement.
And what decides whether the operation even proceeds? It's a fascinating combination of, well, biology and some very high-stakes judgment.
Okay, so let's unpack this. Where do we start?
We have to start where all complexity begins, embryology. You'd be surprised how many surgical surprises trace their lineage right back to these developmental processes.
I've heard this before, that the origin story of the kidney is a huge factor in later surgical life. Tell us about this ascent I've read about.
It's absolutely true. The kidney, you see, it begins its life way down low in the pelvis. It originates from something called the metanephric blastema.
Okay.
And as the fetus grows, the kidneys ascend up into the upper abdomen. But they don't just move up. They also perform this really crucial medial rotation.
So if it doesn't ascend or rotate perfectly,
Exactly.
that sets the stage for these really challenging variations that a surgeon is going to run into 50 years down the road.
That's the critical takeaway. An imperfect ascent means we might see kidneys sitting higher or lower than expected, or maybe a high or low Hiller position. And, imperfect vascular development during this process is responsible for one of the most common surprises, accessory renal arteries.
And those are dangerous if you miss them.
Highly dangerous. Or, less commonly, you might see multiple renal veins. They're easily missed and, well, catastrophic if you inadvertently cut one.
And the venous drainage on the left side, that seems to create the most dramatic variations, doesn't it? Mostly because of how the veins develop around the aorta. What are the signature challenges there?
So the left renal vein, the LRV, it's pretty unique. Because of how the early venous system regresses, the drainage can be highly variable. You might encounter a retroaortic left renal vein.
Meaning it passes behind the aorta?
Right, behind it. Or even a circumaortic vein, which actually splits and surrounds the aorta. Finding this out before the operation is vital because it completely changes your plan of attack.
And that left renal vein isn't just a conduit for the kidney, it's more like a central hub for other major structures.
Absolutely. The LRV is elongated, and it's a confluence of 3 vital tributaries. And you have to identify and secure every single one during the dissection. You've got the left adrenal vein coming in from above, the left caudal vein from below, and then various lumbar tributaries from the back.
And if you neglect any of those,
You are guaranteeing unnecessary bleeding complications. Simple as that.
that sets the stage beautifully. So let's move from that microscopic origin story to the macroscopic landscape. Stepping into the adult surgical field, what do we need to remember about the kidney's neighborhood?
Regionally, the left kidney sits a little higher than the right. It's tucked up under the ribs. Specifically, it's protected by the 11th and 12th ribs in the back.
And its immediate neighbors are, well, they're complex, especially if a surgeon is coming in from the front with a transperitoneal approach. What are those crucial anterior relations that have to be mobilized and protected?
Yeah, you have several major structures just draped over the kidney. Superiorly and to the side is the spleen. Medially, you have the stomach. But the most notorious structure, really, is the tail of the pancreas, which sits right up close and personal with the renal hilum.
And below that?
Below that, you have the large bowel relations, the splenic flexure, and the descending colon.
And posteriorly, what's the kidney resting on?
It's resting against the muscles of the posterior abdominal wall. So you have the diaphragm up high, the psoas muscle medially, and the quadratus lumborum out to the side. You also have to be mindful of the subcostal vessels and nerves that pass just beneath that 12th rib.
And hitting those can lead to what?
Significant postoperative pain. It's a real problem if you're not careful.
Okay, let's focus on the vascular arrangement now, because that's key to surgical control. The LRV, the left renal vein, it's much longer than the right, correct?
It is, and its path is fundamental to its potential pathology. The LRV crosses anterior to the aorta to drain into the IVC. And that specific anatomy, the vein crossing in front, is what creates the classic nutcracker phenomena.
which is when the vein can be compressed.
Exactly. It gets sandwiched between the superior mesenteric artery, or SMA, and the aorta.
That explains the venous pressure problem. So how does the left renal artery, the LRA, sit in relation to that very long vein?
The LRA is basically the opposite. It's shorter. It arises from the posterolateral aspect of the aorta. And critically, for the surgeon, it lies behind the renal vein.
So vein in front, artery in back.
That anterior-posterior relationship is your standard roadmap for vascular control. Surgeons usually find the vein first, trace it back, and then retract it to expose the artery lying behind it for safe clamping.
That makes the order of operations really clear. Before we get into the tumor biology, let's just briefly touch on the surgical approach. You hear that in these highly complex or malignant cases, surgeons often shift from a minimally invasive approach to an open midline laparotomy. Why that specific choice?
It all boils down to control and visibility. Like, transperitoneal laparoscopy is fantastic for early confined tumors, but
But when you suspect things are more complicated,
right, when you suspect pedicle encasement or aortic involvement or potential invasion into the spleen or pancreas, the wide, unencumbered exposure of an open midline laparotomy just gives you the best chance to manage bleeding and get clear margins. Complexity dictates maximum access.
this shifts our focus entirely then to the modern oncology landscape. Because for patients diagnosed with metastatic renal cell carcinoma, the decision about upfront surgery has been, well, it's been completely overturned.
It really has.
Historically, removing the primary tumor, the cytoreductive nephrectomy, or CN, was just routine.
It's been a massive, and I'd say necessary, correction in surgical practice.
Mm.
Upfront nephrectomy was the standard for decades. But major randomized trials, particularly Carmina and Sirtime, they show that the high morbidity and risk of the operation often outweigh the benefit, especially once modern systemic therapies became available.
I have to ask, though, isn't removing the primary tumor always beneficial for the overall tumor burden, even if you start systemic therapy? Why did trials like Carmina and Sirtime shift the goalposts so completely?
It's a great question. The shift happened because that upfront surgery carries a significant risk, it delays effective treatment, and it's a major, major procedure. If a patient is already struggling with widespread metastatic disease.
The surgery itself could do more harm than good.
Exactly. That surgical morbidity can actually shorten their survival time, or just prevent them from recovering enough to start the life-prolonging systemic therapy in the first place. The trials show that for many patients, starting systemic therapy immediately offered the best survival outcome.
That is a profound change in philosophy. So what are the hard, quantifiable criteria that now tell a surgeon, no, do not perform that upfront CN?
We use objective measures now to assess the patient's biological fitness and their disease burden. Key red flags would be a poor risk IMDC score,
IPC.
the International Metastatic Renal Cell Carcinoma Database Consortium score. It essentially tells us the disease is highly aggressive.
And for those of us listening who aren't familiar with that score, what kind of variables made it poor risk?
It includes things like very high calcium levels, low hemoglobin, a short time between diagnosis and needing treatment, and just a poor general performance status.
Right, which brings us to the next red flag.
The second red flag is that poor performance status, often measured by the ECOG score. If a patient is ECOG 2 or higher, meaning they struggle to perform daily activities, the risks of immediate surgery are just generally too great.
So if the biology is aggressive, the IMDC is poor, or the patient is just too sick, what happens instead?
They need urgent systemic therapy. The modern standard is to start targeted therapy or immunotherapy right away, reassess their response and their fitness after a period, and only then consider a delayed CN if the systemic treatment has worked well and the disease biology now looks favorable.
And conversely, when does the surgery still offer a clear benefit today?
It's really reserved now. It's for patients who have favorable risk profiles, lower metastatic burden, excellent performance status, so ECOG zeros or 1 or if they have a symptomatic, bulky primary tumor that's causing pain or bleeding.
So for quality of life, basically.
Purely for quality of life reasons. It's a highly selective process now.
This constant tension between surgery and systemic management leads us straight to the most complex part of the operation, the renal hilum. You called it the battlefield. Why is detailed preoperative assessment of this region the single most crucial step?
Because the hilum, where the artery and vein enter the kidney, that's the choke point. It determines your vascular control. It dictates whether a safe, oncologically sound operation is even possible. If the tumor involves the hilum severely, the surgery provides no oncological benefit and you risk an absolute catastrophe.
What specific things, when you see them on imaging, raise the complexity alarm from high to extreme?
Top of the list is renal artery encasement. That's where the tumor is just tightly wrapped around the main artery. This is compounded if the patient happens to have a congenitally short arterial stump. We're talking less than 1 or 2 millimeters.
And that tiny difference matters that much.
That couple of millimeters is the difference between having enough tissue to safely apply a clamp or ligature and risking avulsion of the artery right off the aorta. That is catastrophic, life-ending bleeding.
Wow. Okay. What else makes that battlefield so treacherous?
Renal vein thrombosis, or outright tumor invasion into the vein. Sometimes it extends right into the IVC, which is a massive problem. Also, any tumor that's abutting or encasing the aorta itself, that immediately demands a completely different level of planning.
And we're back to the embryology again.
Back to embryology. The unexpected appearance of multiple arteries, or a retroaortic vein, adds a huge layer of technical difficulty.
So if the imaging shows this kind of severe vascular involvement, what are the implications for the surgical team?
Well, if the hilum appears definitively unresectable, the team has to be prepared to cancel or postpone the operation and recommend immediate systemic therapy. For localized but still highly complex tumors, severe vascular involvement might mean you have to involve specialized vascular surgeons for aortic dissection and reconstruction.
So it turns a standard urologic operation
Into a major combined vascular procedure, a whole different ballgame.
Let's shift now to the risk of adjacent organ involvement. That's a major concern with these large upper pole tumors on the left. The spleen, the pancreas, the colon are all right there.
They are. And if a large, aggressive tumor has truly infiltrated the spleen, surgical philosophy is clear. Total splenectomy is required to achieve a clear margin.
You can't just shell it out.
Trying to shell out or partially remove an infiltrated spleen is rarely oncologically sound, and it just risks immediate massive bleeding.
And the pancreas tail is particularly concerning because of the postoperative complication risk,
Yeah,
right?
absolutely. Invasion of the pancreatic tail means you have to do a distal pancreatectomy. And while that's often required for curative intent, it brings a significant risk, a postoperative pancreatic leak or fistula.
Which is a severe complication.
It is. It can extend a hospital stay by weeks, require prolonged drainage, and dramatically increase morbidity.
And a large bowel, the colon.
If the tumor invades the mesocolon or the wall of the splenic flexure or descending colon, an en-bloc colectomy is necessary. The guiding principle is always en-bloc resection. You never, ever try to peel a tumor off an adjacent structure and risk leaving microscopic disease behind.
But in the metastatic setting, a multivisceral resection adds massive risk. Does that surgical philosophy bend at all given the systemic therapy options?
It has to. In metastatic RCC, a multivisceral resection has to be extremely strongly justified because the morbidity is just immense. If the patient is undergoing this massive operation but still has widespread systemic disease, they might never recover enough to get the systemic therapy that could truly prolong their life.
It requires a serious discussion.
It requires profound surgical and oncological consensus.
Okay, now we get to the final stretch, anticipating complications. The left kidney has several signature risks that every surgeon preparing for this has to have a plan for. Let's focus on the sources of major hemorrhage beyond the main renal vessels.
The main bleeders are the ones we mentioned earlier, those lumbar veins and the fragile gonadal and adrenal tributaries. They can be torn so easily during mobilization. The fragile splenic capsule is another major source of blood loss. A small tear from excessive traction can lead to rapid, diffuse bleeding that needs swift management.
And the spleen itself.
Right, splenic killer to bleeding if the spleen itself is damaged during mobilization.
Given these high-risk areas, how do top surgical teams mitigate these specific risks? Is it just being careful?
It's more than that. The mitigation starts with relentless preparation. Detailed imaging review to pinpoint every potential accessory vessel. During surgery, it's about meticulous, careful exposure, minimizing traction on the spleen and the pancreas, and they always have vascular clamps, heavy sutures, and hemostatic tools like surgical sponges or special sealants immediately available.
So anticipation is key.
Anticipation is the difference between a controlled situation and a crisis.
Beyond blood loss, what are the other signature risks we need to cover?
Pancreatic injury is a constant worry near the tail, because that can lead to that debilitating fistula risk we discussed. Splenic capsular tears are probably the most common adjacent organ injury, and these have to be either repaired meticulously or, if they're severe, the spleen must be removed.
What if a surgeon tears the colon?
A colon injury around the splenic flexure has to be recognized instantly. If it's minor, it can often be repaired primarily. But if the damage is extensive, a resection might be necessary to avoid a devastating fecal contamination and sepsis.
And finally, that risk to the chest cavity given how high the kidney sits.
That's the pleural breach. The diaphragm is often incised when you're mobilizing a high kidney. If the pleura is breached, it's generally managed pretty easily by repairing the defect and placing a chest drain post-op to manage any resulting pneumothorax. It's expected and managed, not a catastrophic event.
And of course, the risk of blood clots.
Of course, given the complexity and often large tumor burden, aggressive prophylaxis against thromboembolism is routine.
We've laid out all the reasons why the left nephrectomy is so tough, but I've often heard that once the initial hurdles are cleared, some surgeons find the left side slightly easier than the right. Is there a factual basis for that?
There is, actually.
Mm.
And it's a great final piece of anatomical nuance. Once the spleen and colon are carefully mobilized medially, which is the tough part, the posterior dissection plane of the left kidney is often beautifully clean.
Really?
It's an avascular plane. It allows for a simple elevation of the kidney right off the psoas and the quadratus lumborum muscles.
So, provided the major vessels, that complex battlefield we talked about, are secured and respected, that clean posterior plane streamlines the removal. And that contributes to the belief that the overall difficulty might be slightly less than dealing with the IVC interface on the right side.
Exactly. It's an elegant final maneuver after this surgeon has survived the helicocomplexity.
And that brings us to the end of today's deep dive. We've traced the left nephrectomy from the vagaries of embryology and venous development through the anatomical complexity of its neighbors, and critically navigated the modern oncological judgment that determines whether or not a complex surgery even proceeds at all.
You should now have the knowledge to understand not just the mechanics of the operation, but the profound surgical and oncological decision-making process behind it.
So here is our final provocative thought for you to consider. If the renal hilum, with its potential for artery encasement, is the single physical barrier that may shift a metastatic patient from surgery to systemic therapy, and given the ever-improving power of advanced preoperative imaging, how much knowledge gained from these high-tech scans truly influences a surgeon's decision against vascular reconstruction today when systemic therapy offers such a compelling and less invasive alternative?
It raises a vital question, really, about where the line now lies between the achievable maximum surgical extent and the preferable minimum systemic intervention.
A deep question for a deep dive. Thank you for joining us. We'll catch you next time.